you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
Okay, God is wrist pain by doing over-aggressive high fives to his buddies.
Well, this is, and I'm going to talk a little to you about B-lines. Does anyone know what B-lines are? Have you guys heard that before? Yeah, that's right, the B list. Yeah, the other Vicki Noble, not this Vicki Noble. But what we can say here is that B-lines are essentially a marker of interstitial edema. So, for example, what I'll show you, when B-lines are present, there is interstitial fluid, and when B-lines are not present, there's no interstitial fluid. What that means is as the lung starts to fill with fluid, we know that it first starts to fill up the interstitial space. And so when it's well aerated and the interstitial space is empty, you're going to get scatter and reflection, and the sound usually doesn't penetrate below the pleura. As the interstitial space starts to fill up with fluid, you start to get reflections and refractions of the sound in that tissue. And so what that does is it causes these vertical lines that start at the pleura and go all the way to the end of the screen to be increased in frequency and number. And so there have been very good studies correlating B-lines with BNP, with wedge pressure, with ejection fraction, and the more B-lines you have, the higher your wedge pressure, the higher your BNP, or the lower your ejection fraction. So again, the B-lines here start at the pleural line and are these vertical lines that are indicating that there is interstitial fluid in the lung. If you don't have fluid in the lung, the sound usually travels to the pleura, and then you get a reverberation artifact because there's nothing distal to that pleura, so you have a horizontal line. So horizontal lines, which they call A lines, mean no fluid. Vertical lines, which we call B lines, mean fluid. And I can tell you, this is a pretty dramatic thing to see. It's not like it's very subtle. We actually did, one time when we were talking about this, somebody said, oh, well, that's really complicated. I'm not sure I'm going to be able to see that. So we went to my nephew's 5th grade class, and we showed him his classmates a bunch of clips of A lines and B lines, and said, you guys just tell us if the lines are going up and down or the lines are going sideways. And 5th graders could do it. So if a 5th grader can do it, I think you guys can do it. Okay. So by convention, we use the low-frequency probe, so either the terminal probe. You usually set the depth kind of deep because, again, this is an artifact, so we're just trying to standardize the way we look at this. And so you set it to about 18 centimeters. And if you have more than 3 vertical lines in your field that you're looking at, you start to worry that something is going on. Now remember, not everything that fills up the interstitium with fluid is CHF. So you still have to be a doctor and know if the patient has pulmonary fibrosis or has a bad pneumonia or has something else going on that can cause the interstitium to fill up with fluid. But it's very useful in the patient who has both COPD and CHF and comes into the emergency department wheezing. And we know what we usually do. We usually give them steroids, Lasix, albuterol, and Atrovent, and they get all of it. And so if we can look at these patients and say there's vertical lines, I'm not going to give steroids and albuterol, I'm just going to treat their interstitial fluid, or there's only A lines, those horizontal lines, I'm not going to give Lasix, I'm just going to give steroids and albuterol, I think we can be much more directed and specific in our treatment. And there have been studies looking at this. The way we really usually look in the emergency department is we look in the 4 zones, kind of up, superior segment, middle segment, and then 2 lateral segments. And we just try to see, are there more than 3 B lines in each of those segments? The nice thing is that the more B lines you see, the more fluid there is. So if it's bilateral in all the segments, it's very specific for CHF.
Question.
Yeah. And you can see it also when they're sitting up. So again, most of us, for example, when we look at the models, if the models have been lying flat for a little while, most of us get a little atelectasis and fluid collection in our lateral segments. So seeing a few isolated B lines in the posterior lateral segments of a supine patient is not pathologic. But if you're sitting up, and again, usually these patients come in, they're dyspneic and they're wheezing, and we're trying to decide which treatment path to go down. If they're sitting up, you can evaluate them sitting up, and if you see the B lines, then you know that there's interstitial fluid. So again, these are just some clips of the same thing. You can see here's the pleural line, And you can see these horizontal A lines, that's the aerated lung, so COPD, asthma, things like that. And over here, you can see these vertical white lines, and that's the lung with fluid. And the interesting thing is that as the fluid collects, I think when the lines start to coalesce, that means that now we have not just interstitial fluid, but alveolar fluid. So you can see that the more white there is in that vertical plane, the more fluid there is in the lung. And there's lots and lots of studies on this. This is kind of an old slide, but the positive predictive value here is very high. And actually, this is a study that we did at Mass General, and the reason I put it up here is because if you have B lines in all the fields, we found that you had an infinite likelihood ratio of having CHF. And anyone who knows anything about stats knows that to get an infinite likelihood ratio is a little ridiculous. It's like saying you're 100% right all the time. So of course, I'm sure that maybe our sample size was a little off, or something there is a little strange. But still, that's a pretty powerful statement. If you see the B lines in all of the zones, all 8 sides, and the person is dysmic, you worry that they have CHF and you can treat them with Lasix. The other really amazing thing about B lines, though, is unlike the chest X-ray, these B lines respond in real time to your therapy. So we know that one of the problems with chest X-ray, especially for anyone who's a hospitalist here, is that there's a lag time behind where the chest X-ray still looks wet, but the patient is already improving. So what we did is we looked at patients getting hemodialysis, because they're the perfect B-line patient, right? They come into dialysis, they're volume overloaded, and within hours they get the volume removed, and we wanted to see if the B-lines would respond in real time. And what we found was that within 4 hours, so within minutes to hours, you could see a decrease in the B lines as the volume is removed. And this is a great case that I show all the time, but this is basically a patient who came in, all 8 areas were very fluid overloaded. You see the white lines everywhere. And all we did was put them on CPAP and check them an hour later. And you can see that the CPAP pushed the fluid out so that now, we knew the patient was better anyway, but this is sort of just to prove to you that this is a real-time measure of responding interstitial space. So the fluid goes away, the B lines resolve, and it resolves in real time. Now, from an emergency department perspective, this is exciting, but probably not that exciting, because usually patients are in our departments hopefully for only a few hours, and so I know that's not always true, but you treat patients, you can see they get better. But imagine if you could do this on the floor. Think of all the portable chest X-rays that we get every day in the ICU or on the floor or in our wards on patients that have had treatment 8 or 10 hours ago, and the chest X-ray looks exactly the same. If people could do their own lung ultrasound and look at these changes in real time, you could avoid an enormous number of portable chest X-rays.
Well, Vicki, instead of just imagining, I actually did some calculations. It took a supercomputer that could do 42 petaflops per second of data crunching, but I found that we could save 87 quadrillion chest X-rays per year in the U.S. if admitted patients got daily ultrasound instead of daily chest X-rays, and the information would actually be useful.
And so I just put it out there as a food for thought kind of thing, because I think this is a really low-lying fruit, and it's something that I think ultrasound is actually better at than chest X-ray. A little bit about a few other lung ultrasound findings that I think are helpful also, because remember, not everything that is B lines is going to be CHF. We have pneumonia patients, we have bronchiolitis patients, we have ARDS patients. And so there's a few other things that you can see, especially if you start doing more lung ultrasound, and that will start to help you differentiate these patients. This is a picture of this is a rib shadow, and there's another rib shadow kind of over here, and you can see the lung is sliding back and forth, but what do you notice about that pleura? It's very thick, it's very irregular. I call it lumpy bumpy. It's very lumpy bumpy, and there's like a little bit of fluid even here. When you see a pleura like this is not someone who flashed pulmonary edema into their B lines. This is somebody who's had chronic inflammation, chronic irritation, chronic pus in their pleural space. And this is something where you would start to worry more about ARDS or pneumonia in addition to the B lines. And so this finding, along with, here's another picture. It's not quite as obvious, but you can see here's a nice thin pleural line, and here's a little more lumpy bumpy pleural line. The other thing that happens is in ARDS, you have skip areas. We know this from CT imaging. So if you see B lines in one zone, and then A lines here, and then B lines in another zone, you start to worry that there's something that's not uniform, so either ARDS or a multifocal pneumonia. So that's something else that can be helpful. And then finally, as the person starts to get really sick, what you'll see is the lung starts to consolidate. And this is actually not a liver. This is a lung. Yeah, it's not good. And the reason I know that is because if you have consolidation around the bronchus, what will happen is the difference between the tissue density of the air in the bronchus and the tissue around the bronchus will give you these white lines. So in a liver, the septated things are going to be black because they're fluid in the veins. In a lung, what happens is that air now shows up as white bronchograms that outline the bronchograms. And if you hold your probe still, this is an excited person, I think it was probably me, so they're like kind of going fast. But if you hold your probe still, you can actually see the air moving through the bronchograms. That's a very, very specific sign for consolidation in pneumonia. The other thing that you can see here is you can actually see a little pleural peripneumonic fusion right at the very end of the clip. I can tell you right now that the specificity that you see in this clip does not show up on your X-ray, and I'll show you some pictures of that in a minute. Okay, so now we have a few other findings. So the pleural line abnormalities, the consolidation, and the skip areas. So now we're going to think about it in a little more complicated terms, not just COPD versus CHF, but we're going to think about the full spectrum of pulmonary disease. And one of the things that happens a lot in the north, in Boston, is we get bronchiolitis season where everybody gets a cold at the same time, and we get about 3,000 sniffly, coughing, crying 5-year-olds come to the emergency department in the same week. And how do you know which of those kids are the sick kids and which of those kids are the kids that are okay to go home? Well, there's been a ton of studies on this. You can do scores, you can look at hypoxia, you can look at retractions, but there isn't a real consensus about how to know who to admit and how to risk stratify. One of the studies that looked at this said that if you have a larger ED visit volume, if you have no PCP, if you're hypoxic, or if you had a chest x-ray performed, and that's probably a marker of the doctor being like, you know, something's not right with this kid, I'm just going to order a chest x-ray because I'm worried about them. And so all of these things showed an increased length of stay and increased severity of disease. However, if you look with lung ultrasound at these kids, you'll start to see not just that there are the findings that I talked about with the B lines as the interstitium fills up, but you can also start to see these lumpy, bumpy B lines and these little pleural consolidations. And those are markers that the kid is sick, because now they're starting to damage the lung parenchyma, they're starting to irritate the pleural line, so it's a more chronic process, and that makes you worry about the kid a little bit more. So again, basically, chest x-ray in these kids is not very helpful, and that's been well demonstrated, that the findings of a sick bronchiolytic kid are only present in less than 50% of the patients. But the lung abnormalities, so the subpleural consolidations, the B lines, and the pleural line abnormalities were much more easy and much more likely to predict who needed admission and who was sick. And here, what I'll show you is that you can see on the left, these blue boxes are the ultrasound findings, and the red boxes on the right are the X-ray findings. And this is a very common risk stratification score looking at trying to divide kids into mild, moderate, or severe. And you can see the ultrasound findings are much more predictive than the chest X-ray. The chest X-ray is essentially the same between moderate and severe, whereas you have a statistically different, significant difference between the lung ultrasound findings. In the mild kids, the X-ray and the ultrasound's about the same, but you probably would have known that just clinically from looking at the kids. What we want to have is a better way to stratify the moderate to the severe kids to see who we have to admit and who we can send home. Now, these are just a few studies. This isn't, huge numbers, but I think there's a lot of potential here because we don't really have a good way to look at these kids in a quick and efficient manner and test them. The other thing they found was that the lung ultrasound findings matched the resolution of the symptoms and the resolution of the severity score over time. So again, the top is the lung ultrasound findings and the bottom is the severity score, and you can see they both resolve with the same slope. And again, these are kind of, these are sort of thought-provoking studies, but I think it's something that's really interesting and has a lot of potential, so that's why we're spending some time on it.
So what were the findings exactly?
So the findings are the subpleural consolidations, numerous B lines, and pleural line abnormalities. If you have all three of those, then you're in the severe camp. If you have two of the three, you're in the moderate, and if you have zero or one of the three, you're in the mild. So subpleural consolidation is basically, you can see that this pleural line is irregular, but see how there's like almost like a V, it's almost like an infarct. There's like a V-shaped irregularity there with some black fluid below the lung. And what you'll see, and you see this in ARDS too, I'll show you that in a minute, but what you see is as this person gets sicker, there's more and more areas of that black fluid below the pleural line.
So how does that differ from pleural line abnormalities?
Pleural line abnormalities just mean it's kind of lumpy, bumpy. When you start to see the black fluid below it, that's a subpleural consolidation. And it's a spectrum. You know, it's not that it's an either or. It gets worse and worse and worse and worse. Okay. So that's bronchiolitis, which I think is kind of interesting. All right, pneumonia. So again, all the same findings are present when you have inflammation in adults or pneumonia process as same thing with bronchiolitis. And again, it's more of a spectrum. So you go from a little B lines to a lot of B lines to some pleural line abnormalities to some subpleural consolidations and then to that full consolidation with the air bronchograms that I showed you before. Okay, so here is a patient we had, and you can see here's the bunch of B lines, right? So there's all this wetness. There's a little bit of lumpy, bumpy pleura over here. But underneath this is something weird, right? Like usually if you have a skip area, you're not going to see these little bronchi, and I'm in the chest. I'm you know, at the fourth or fifth intercostal space. So this is where you start to worry that there's a consolidation underneath all this kind of B lines and interstitial fluid. And so I can tell you, because we do this more now than we used to, is that you'll see this more often than you expect, is that you can see these areas of focal consolidation. And again, not that it changes things. Usually you know if somebody's sick, but it may increase your likelihood of admission. It may make you think more about IV antibiotics versus PO antibiotics, or about bronchs to look for obstruction. Okay, so again, here's the subpleural consolidation. Here are the air bronchograms, which are the white lines of the bronchus as it's being outlined by the consolidation. And there's a whole bunch of studies recently looking at lung ultrasound and pneumonia to see if we can make the diagnosis any differently using chest x-ray versus lung ultrasound. So this was a study, again, out of Italy, but they said this was a feasible thing. You know, you go into the room, and the nice thing is you can do this as the patient is sitting up. You can do it as you're getting a history, kind of talking to them. And they found that their diagnostic accuracy was comparable to CT. And the reason for that is they basically based all of their accuracy on these two findings. If you see air bronchograms and you see alveolar consolidation, then that patient has a pneumonia, and that patient, you know, sometimes you can see those in ways on the ultrasound that you can't see on the chest x-ray. Here, this was another study that compared chest x-ray positive to lung ultrasound positive, and you can see, here, so the chest x-ray positive, lung ultrasound positive, so that means that both groups caught those. But the chest x-ray negative, lung ultrasound positive, chest x-ray missed 27 patients. Now, these are probably the patients who we send home with antibiotics because they have a fever and a white count and they look sick anyway, and we say, well, you know, your chest x-ray may bloom a few days later. So whether it changes what we're going to actually do with our patients, you know, may be up for debate, but I can tell you that this sometimes does push you when you see this consolidation on chest x-ray to giving antibiotics and not waiting for them to go back to their PCP or come back to the ER. And here, again, this was a study looking at chest x-ray versus lung ultrasound, and they found that and this is compared to CT, so the gold standard is a CT scan, and they found the ultrasound sensitivity and specificity to be in the high 90s, whereas you can see the chest x-ray sensitivity and specificity, and we know this from our clinical practice, is not anywhere near as close. So 85% sensitive, 67% specific. And we know this because we oftentimes give antibiotics to the person who has a negative chest x-ray. So I think, you know, again, there may be some room for improvement if we're using lung ultrasound to make these diagnoses.
Okay, let me let that sink in for a bit. Ultrasound is not something you can do for pneumonia. It's better than chest x-ray. That's right, let me say it again. It's better than chest x-ray. It's not just that there's less radiation. It's not just that it's quicker and cheaper. It's better.
There's probably 1,000 cases like this in the literature where they show all three, just to make a point. And you can see here is the chest X-ray, and this is like 1,000 chest X-rays you see, but the diaphragm looks pretty clear. Maybe it's a little hazy down here. It's a little hard to say. Here's your lung ultrasound. You can see the air bronchograms. You can see the pleural effusion. You can see, the consolidation, and that's in these posterior lateral lung segments on your CT scan. So not that, you don't necessarily need to go hunting around or getting CT scans on all these people, but I think that the ultrasound accuracy for picking up these smaller consolidations is very high. Yes?
One place I can see it's being really helpful with pregnant patients.
Absolutely. Or kids, right? So people you don't want to irradiate over and over again. And the other group that I think this could be really helpful on is on the monitored patient. So the person who's going to get repeat chest X-rays every day to see if they are, getting better. Maybe we could skip a few of those chest X-rays and use lung ultrasound to monitor them instead. This is another one comparing echo or ultrasound and chest X-ray compared to CT. And again, these are the same pictures you'll see over and over. You'll see these kind of non-specific chest X-rays, and you'll see that they can find this consolidation because of the B lines, the pleural abnormalities, and the consolidation. Yes?
Are you looking in the same 4 spots, like 2 anterior, 2 lateral?
That's a great question. They haven't defined the scanning protocol for pneumonia as carefully as they did for pulmonary edema. What I would suggest is that, yes, you would want to look in those same 8 zones. Obviously, it doesn't take a lot of effort to look here, wait a second, look here, wait a second, look there. You could probably do 20 zones if you wanted to, and it would take 10 minutes more. But I think starting out, as you're looking, to look in those 4 zones on each side is a pretty good coverage of your thoracic cavity, and so that's what we use. With the depth of 18, yeah. The other thing, just to point out, because your question kind of brings it up, is that obviously if there's an isolated pneumonia here and it doesn't touch the pleura and there's aerated lung between the pleura and the pneumonia, you're going to have a hard time seeing the consolidation. You may see the B lines because the interstitium will still fill up with fluid around that pneumonia, but you may miss the consolidation. So again, all of these things have to be used in a clinical context, which is why it's very powerful in the hands of a clinician, maybe not so powerful in the hands of a imaging specialist. Any other questions? Yeah.
What we're using for peds?
For peds, it depends on the size of the kid, but the little tiny infants, you're going to use a linear probe just because you don't need that much depth and you get much prettier pictures. But if they're from 5 and up, usually we just do the same as we do with adults. So infants, I think, and neonates are a little bit different, and most of the studies in them have been done with linear probes. But anyone who is above infant stage, so to me that's like 5 and up, 5 and down kind of thing. But bigger kids just use the same protocol you would with adults. So the peribronchial thickening is not something that's not a lung ultrasound finding. I think what you see on the lung ultrasound is you'll see more B lines because that's a marker that the interstitium around that bronchus is full of fluid. So I think the lung ultrasound equivalent to peribronchial thickening is B lines. But you don't see like a halo effect around the bronchus. When you get consolidation, what you see are those white streaks through the tissue, but you're not going to see that on the lung ultrasound. The biggest challenge, I think, with lung ultrasound is it really is a paradigm shift in terms of the clinician being able to trust new findings and use them in replacement of old findings. And so I think that's the biggest challenge. And the way you get used to that is you do chest X-ray and lung ultrasound for a while and convince yourself that your findings match. And then I think it becomes obvious fairly quickly, honestly, that the lung ultrasound gives you more data than the chest X-ray. Okay, so the last thing I wanted to talk a little bit about, how many intensivists are there here? I know you're an intensivist, a few of you. So ARDS, obviously, as an emergency department diagnosis and management, if you're lucky enough to work at a place where you don't have divert or ICU problems, usually these patients go right upstairs. But I'll tell you that we do end up managing them at our hospital for some time. And so I found that lung ultrasound is very helpful in this, because not only can it help manage the diagnosis, which is, I'll show you in a second how you make that diagnosis, it also helps you manage the vent strategies. So if you are having trouble ventilating someone and you increase the PEEP, you will see a change in your lung ultrasound within minutes that goes from a spectrum from consolidation to A lines. So I'll show you, there's a very cool study from France that I'll show you in a second. Okay, so first, how do you make the diagnosis? Well, this is a kind of seminal paper out of Italy, and basically it's the exact same thing I was just talking to you about for pneumonia, for bad pneumonia, or bronchiolitis, because of course ARDS is essentially a spectrum from an inflammatory process to a consolidative process. So the more B lines you see, the more pleural line abnormalities, the more subpleural consolidations, and the skip areas, which I think are fairly specific to ARDS or multifocal pneumonia. And again, this is a study that compared pulmonary edema to ARDS. And what you'll see is that the difference is really in this pleural line abnormality, spared areas, and consolidation. You will see all that in ARDS, but in pure pulmonary edema, you're not going to see that, because it's more of a fluid process and not an inflammatory or consolidative process. And this is just showing the same thing. Okay, so what does that look like? So pulmonary edema, again, should be more uniform, whereas ARDS is going to have some spared areas. Pulmonary edema should have a nice thin pleural line, where ARDS or inflammatory processes are going to have this irregular kind of bumpy pleural line. And this is more subtle findings. Okay, so why would this be useful? Why would you want to have all these kind of spectrum in your head? Well, what this group did was they took people with ARDS and they randomized them to getting PEEP or no PEEP, and they did an ultrasound. And then they changed the groups so that the people who had PEEP, they took away their PEEP, and the people who had no PEEP, they gave them PEEP, and they did another lung ultrasound 15 minutes later. And what they showed was that you can actually look at your patient's ventilatory status in real time using ultrasound. So it was French, so zero PEEP is called ZEEP. And if you have ZEEP, you have consolidation. And then they added their PEEP, and they went all the way from consolidation to A lines. Now, most of us probably know that barotrauma and like increasing the PEEP that fast is probably not a good idea. What you probably want to do is you want to go more gently from consolidation to a bunch of B lines to fewer B lines than to A lines. So again, if you can stagger your ventilatory strategy so that you're increasing the PEEP more gently and you're going all the way from consolidation to A lines over time, that's probably a better way to do it. But this was the first paper that showed within minutes of changing the PEEP on your ventilator, you can actually demonstrate an improved aeration in the lung tissue using ultrasound. And so to me, again, it's not necessarily the biggest impact on an emergency department patient, but if you think about all the ICU patients who are getting serial chest x-rays or serial even CT scans, to go down and for ARDS and traveling with your ventilator, it's very, very time consuming and cumbersome. So I think this has a lot of potential in those patients. And again, this is kind of showing it on a more zoomed in level. Here is your consolidation. Now you increase your PEEP, you go to sort of subpleural consolidation, but you're starting to see some better aeration here. And now you're back to B lines. And this is probably the way that you want to do it. You increase the PEEP a little bit and you look to see the changes on your lung ultrasound. Okay, so that is basically lung ultrasound in 45 minutes. And I know like some of the stuff at the end is more, sort of new ideas and kind of cool studies that I think push the envelope in terms of getting us to think about how we use our diagnostic tests. And we'll talk about this a little bit also with resuscitation, but I think portable chest x-rays, we use them, but we all know that sometimes we order the portable chest x-ray and we're already treating the patient or doing something before we even see the portable chest x-ray. So I think we use it more of a documentation method than necessarily a diagnostic method. And so thinking about lung ultrasound is a way to kind of improve on that and avoid ordering all these serial chest x-rays, I think is something that's kind of interesting. I think that's it.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.